Welcome to Cardio Insights, the podcast where we explore how digital solutions are transforming cardiovascular and emergency medicine. Featuring thought leaders from leading institutions across the globe, this series of conversations unveils the power behind clinical algorithms and decision support tools, and how they are changing the way we diagnose and manage cardiac conditions. From their impact on clinical practice, their benefits for patient outcomes, and the challenges they pose to health systems in terms of implementation and regulation, this podcast is intended as a precious resource for healthcare professionals in cardiology and emergency medicine who are curious to learn more about this exciting field. I'm your host, Matthew Chaffert, and you are listening to Cardio Insights. So welcome, Professor Gibson, to this episode of Cardio Insights, the podcast where we explore how digital solutions are transforming cardiovascular and emergency medicine. For our listeners who might be new to you, you are a professor of medicine at Harvard Medical School, chief executive officer of the nonprofit Baim Institute for Clinical Research and the Academic Research Organization PERFUSE, serving as well as the Interventional Cardiologist at Beth Israel Deaconess Medical Center. You are known as the inventor of several coronary blood flow measures widely used today in clinical practice, including the TIMI frame count and the TIMI myocardial perfusion rate. Throughout your career, you have published more than 700 peer-reviewed papers and led numerous clinical trials, including the Pioneer trial that demonstrated the superiority of dual therapy over triple therapy in patients with atrial fibrillation that requiring stents. You're also a member and fellow of numerous societies, including the American Heart Association Council on Atherosclerosis, Thrombosis, and Vascular Biology, and the Commission of Professional Education Committee. So in this episode, we want to explore with you the role of clinical decision support tools and solutions in cardiology, the impact that these technologies have had on the management of acute and chronic heart conditions, and also take a sort of like forward-looking look at the future of cardiovascular care in the era of artificial intelligence and digital health. So from your perspective, how have clinical decision support solutions changed the landscape of cardiology in recent years, and do you see an acceleration of that progress in terms of the capabilities and adoption of these technologies in clinical practice?
Well, thanks for having me on today. It's really been breathtaking, right, to see the advances in clinical decision support science. That's the good news. AI, machine learning. You're not a company unless you have AI and machine learning. That's the good news. The bad news is that the implementation science is lagging far behind. There's a popular expression, culture eats strategy for breakfast. We have great strategies, but the cultural changes inside of hospitals are so big and hard to surmount that it's been a challenge. While there is good science supporting clinical decision tools, we have to make sure that the tools are doing something for clinicians rather than something to clinicians. Mm-hmm. We also have to make sure all the stakeholders are aligned. You have a lot of P's here. You have the physician, you have the patient, you have the payer, you have the person at the top of the hospital. So all those have to come together. And we don't have really great alignment of all those strategies. Each of those different groups have different goals. Mm-hmm. And we have got to get alignment around those goals. The patient should come first, but we have to get better alignment. So this is not the end. This is not the beginning of the end. This is the end of the beginning, where we have to reemerge now with changing culture to really, really take advantage of all the good science. I like to say that science is easy. People get mad at me when I say that. But people are hard. Mm-hmm. We've solved a lot of the science issues. The answers are very clear. It's the cultural barriers, the people problems to making this happen, which are the challenges that are before us.
Mm-hmm. And so, that's an element we've talked a lot about in the other interviews that we've done today with some of your fellow cardiology colleagues. And, this piece of fostering adoption and fostering, the implementation of tools that fit the way, healthcare professionals work seems to be a recurring theme, and it's to be a major pain point that, goes much beyond, let's say, the level of the technology that we have today. But in terms of what you've seen, over the years, in terms of new solutions coming up to support the way you treat acute and chronic heart conditions, can you tell us, how your practice has evolved and how some of these tools have changed the way you deliver care on a daily basis?
It's fascinating. You said tools, and then at the very end you used the words deliver care. And I think those are two separate pieces of information. On the tool side, I think we've got to get to a place where MD doesn't stand for manual data entry. We've been entering all this data into the EHRs. We've got to move away from technology where we work for technology instead of technology working for us. That's got to be a transition. It's so frustrating. We've worked so hard to enter all this information into the systems. The systems have to be able to give us the information back in ways that don't require further work on our part. We don't want more clicks.
Yeah.
Okay? You use the words deliver care. I think one tool today that came up in our discussions that actually was used and is good is a tool that, say, for concussions, not only assesses risk, okay, there's the assessment of risk, then there's a decision about acting on that risk. The third D is doing something about it. This tool was very helpful because it actually helped people do something about it. It set up those outpatient visits in an automated fashion. In other words, it reduced the caregiver's workload. So there is the data, the first D, there's the decision, the second D, and then there's the doing, that's the third D. We heard from Jim Januzzi that they have a heart failure implementation team that spends an hour with the patient doing things. That's what we have to focus on. It's really the third D, the doing, that really needs some work, and it's a people problem.
And there's the doing on the clinician side and the doing on the patient side. And we see also, the, let's say, remote monitoring technologies coming up or being, let's say, common part of the way we deliver care today as well. How do you see these technologies evolve, and how do you see the impact that they have on, patients being empowered to take care of their condition?
Well, the letter that comes after D is E. You said empowered, but you're only empowered if you're educated. I think we had those three Ds, but the third E that has to begin the E series is the education that comes after it. We've got to make better educational tools for patients. We know patients will hear about 1 out of every 3 words you say. We have got to have our best communicators making content that's free and available and accessible to everybody to do that education. A doctor's visit is more than 5 to 20 minutes. It really is something that should go on for a long time after the visit with the right kind of educational tools. A doctor or other healthcare professionals not going to be able to do it all in 20 minutes. It's going to take a lot more sophisticated, careful, studied approach with good communicators to get the job done. One of the flaws in communication is that communication actually occurred. I think oftentimes healthcare professionals don't communicate with the patient not just at their educational level, but they fail to establish a connection. We usually call EBM evidence-based medicine. I think evidence is necessary, but it's not sufficient. I think you've got to also establish an emotional connection with a patient. So I call it emotional-based medicine. I think it runs the opposite of what we think in medicine. I think we often think we are neutral. We must be, impartial and neutral. And, no one cares how much you know until they know how much you care. And we've put up a barrier between us and our patients. I think in our communication style and how we educate people, we've also got to use our hearts to engage them and to show that we care about them and their understanding of this content.
I think that brings an interesting piece. That's the having that empathy between and in the patient-doctor relationship. You touched on before that you don't want more clicks in the way you work, and something I've read in the preparation of the interview was that you had also a large part of the medical community saying that we treat the screen, we don't treat the person that's behind the screen. And the thing I'd like to talk about is we talk a lot about artificial intelligence these days and what it can do in terms of processing automatically information, recording the vocal, let's say, elements of a consultation to automatically transcribe it so that clinicians don't have to do it. How do you see this type of technology, artificial intelligence, playing a role in reestablishing potentially this empathy that's so important in ensuring that communication is flowing well between the patient and the clinician, and that there is this level of empowerment that the patient will understand what it needs to take to have sustainable behaviors in the future to address the condition that they are concerned with? How do you see this in the future being part of the care?
Oh, I guess I was dumbfounded when a group came in to begin to implement some of the EHR stuff in our cath lab, and they literally had the data entry tool or the computer across the room with the nurse having her back turned to the patient. It begins with, looking at the patient. And I demanded that, all that be rearranged so that the nurse is actually looking at the patient. So they're very simple things. I just now in the past 2 weeks have been using a tool that's an AI-based tool for all my meetings. So I'm on meetings a lot of the day. And this tool takes notes. It doesn't miss anything because it's transcribing everything that's said. And it's almost absolutely perfect in its transcription. And then it creates a summary of all the key points. And at the end, it has all the action items. It's just revolutionized my world because I was sitting there writing out on a yellow notepad, a legal pad, everything, and then typing it in and transcribing my notes. Now I don't do any of that. I just sit there and I just look it over. And if it's accurate, I save it to a folder, or if it's inaccurate, I edit it. I think we're there. I think we are there where I could sit there with you and look right at you in your eyes, talk to you, and you could look at me in my eyes and we'd talk, and all the notes would be taken for us. And, what I would do is I would look over the notes at the end. Perhaps we could look over them together. And if you disagreed with something or I disagreed with something that was said, we could do it right there on the spot. That's where I see the future's going. I do think we're there. So I think, again, we've got to have tools that facilitate engagement rather than get in the way of engagement. And I think we're there. These tools should actually improve our connection rather than be a barrier to our connection. But we have to have the cultural changes to adopt them.
Some of these topics are, I think, absolutely valid across basically every condition. It's not just specific for cardiology or emergency medicine. Is there an aspect where these technologies are potentially in the future even more relevant for cardiology and emergency medicine? Do you know certain use cases where you could say this is really going to change the way we practice?
I think what I just said about emotional-based medicine isn't going to change. But I think one thing that happens in the emergency room, for instance, is you've got to make decisions immediately. I worked a lot on decision algorithms and ways we communicate with patients surrounding life-threatening emergencies. You've got to very, very, very quickly exclude a life-threatening problem. There's no time really for establishing a relationship right then. So I do think we could have algorithms that help us very quickly identify the key things that can kill someone, for instance, with chest pain, like a dissection or a heart attack or, a esophagus that's torn. Let's begin by excluding the things that are going to kill you immediately. Then let's move on to other things. I think an organized hierarchical approach with the assistance of these kinds of algorithms could be helpful in excluding the life-threatening things quickly so that we can move on to the other things. Now, I think one problem is in ERs and for cardiologists, if we think someone's not going to have a heart attack, that doesn't mean they don't have a problem with their GI system, right? So we shouldn't say the person's fine.
Yeah.
They're fine from a cardiovascular perspective, but, we have got to take care of the whole patient, not just the cardiovascular system. And AI hopefully will keep us honest in that regard.
What do you think would be the benefits on, let's say, at a health system level and at a public health level, of having these solutions in place and running, let's say, on a daily basis? What would you, let's say, anticipate the benefits would be on a broader scale?
We talked about the P's. There's at the top the patient, there's the physician, there's the payer. But then there's also the final P you're talking about, which is the public health, all the P's put together. I think an informed public is a healthier public. I think our biggest battle right now is not in information, but battling misinformation. I think we have got to work towards reestablishing the trust of our patients. I think COVID did a lot to really diminish the trust of providers. I think it really diminished the trust also of our government and the agencies that give us recommendations. I think we have a lot of work to do on educating people about how science works. I think we all want the truth, and people think science means truth. And they think truth is something that's permanent and never changes. The truth changes. And we've got to get the public used to the idea that as we learn more, our truth sometimes changes. And in COVID, we learned things, and it seemed like the truth was changing. And that was very confusing to the public. So I think we've got to do a better job of reestablishing truth, letting people know how science works. I think that's a big challenge in front of us.
And we have a recurring question we ask every guest on the show, and that's a bit more, let's say, fantasy driven than what we talked about. But, if you could have any type of digital solution in your clinical practice that addresses one of the essential pain points that you face and have it tomorrow, what would that be?
Well, we're working on tomorrow today. For a few years now, we've been working on a decision support tool that does the following. Patients want to know about them, not the population, but what about me? What about me and my risk, and what should I do, not the population? Secondly, someone's risk changes over time. Let me give you an example. If you take a blood thinner, if you don't bleed on that blood thinner, you have passed your bleeding stress test. You're a different patient at the end of that. So we need to, rather than just assess the risk right now, we need to iteratively assess risk. It's a little like expecting us to predict the weather a year from now. We're going to be doing a much better job if we predict the weather a week from now, right? So we need to iteratively assess risk. Patients want to know what's going to happen to them, not the population. We need very specific individual risk. We also want to give people a give or take around that assessment of risk. Your risk could be 5%, give or take 3%. And we also want to take into account their preferences. Like, how do you rank death, a stroke, a heart attack, or bleeding? People may rate those outcomes very differently. Now, there's population ratings of those, but no, we want to use the individual person's assessment. So where we've gotten with the tool we've developed is it assesses your risk iteratively over time. It gives you a give or take around that risk. It provides you that risk in a way that's displayed if you are anumeric, the number of bodies there. And finally, if you're someone who values preventing a stroke over a bleeding event, it does a different calculation than if you're more worried about bleeding than a stroke.
Yeah.
So we want to take patients' preferences into what they want to prevent and what their risk adversity is. And we're finally there. So I'm very excited about it.
Amazing. Thank you so much, Professor Gibson.
Thank you so much for having me today. It's been a real pleasure.
Thank you for listening to this episode of Cardio Insights. We hope you enjoyed it. If you want to dive further into other aspects of digital solutions in cardiovascular and emergency medicine, check out the other episodes of the series. To support the show, you could share this episode with your surroundings and leave a 5-star review on your preferred streaming platform. Cardio Insights is a podcast brought to you by Roche. Thank you for your time and see you in the next one.